RN Link presents HCC in Inpatient Setting 2025 updates. You can also obtain the CEU certificate for $20 by clicking the link below on the description section. The presentation offers one CEU approved by BRN, ACTIS and AHIMA. Learning objectives. At the end of this training session, the CDI Specialist will be able to 1. Define risk adjustment, risk scores, hierarchical condition categories, HCC, and PSI 90. 2. Specify examples of common risk variables. 3. Review examples of HCCs, example 30-day readmission diagnoses. 4. Understand data analytics and how it is applied to the risk adjustment scores. 5. How to reduce risk within the inpatient setting. You will find also the Appendix A, CMS HCC listing V28.0 attached to the presentation. Disclaimers. This material is designed and provided to communicate information about clinical documentation, coding, and compliance in an educational format and manner. The presenter is not providing or offering legal advice but, rather, practical and useful information and tools to achieve compliant results in the area of clinical documentation, data quality, and coding. Every reasonable effort has been taken to ensure that the educational information provided is accurate and useful. Applying best practice solutions and achieving results will vary in each hospital/facility and clinical situation. What is risk adjustment/risk scores? Risk adjustment levels the playing fields between patient outcomes and the risk among specific patient groups. It includes demographics like age, sex, eligibility, and comorbidities, chronic conditions like CAD, CHF, COPD, pulmonary fibrosis, osteoporosis, multiple sclerosis. The importance of risk adjustment. 1. Accountable care organizations like Medicare and commercial. 2. Medicare Advantage plans. 3. Value-based purchasing both for hospital and provider fee. 4. Improves predictability of costs, quality of care and readmission risk. 5. Used in outpatient setting as well as inpatient setting. Risk Adjustment Scores or RAF. It is a calculation used to identify the costs of healthcare services to a particular beneficiary base. The higher the risk score is for a particular beneficiary, the higher the healthcare costs will be for Medicare. What are hierarchical condition categories or HCC? 1. It is a form of case mix index. A. Use math to settle a specific rate so quality of care can be isolated, understood, and compared. It is a big part of VBP. B. HCCs place patients into different buckets, categories, based upon the diagnosis codes submitted on claims. C. These buckets group patients from clinical patterns and from similar cost patterns. D. More predicative of readmissions and future costs than MSDRGs. 2. Used for payment methodology. A. CMS HCCs set capitation payments to Medicare managed plans. B. In combination with fee for service to compensate a COS. C. Risk adjusts cost and quality measures for VBP of both hospitals and physicians. An example of risk adjustment in the value-based world. In Medicare Part A, 30-day all-cause hospital readmission measure. 30-day readmission examples. Diagnoses include AMI or heart attack, heart failure, pneumonia, COPD, CABG, total hip arthroplasty and total knee arthroplasty. Note: review hospital claims from the year before hospitalization, and any secondary diagnoses from admission are used for risk adjustment determinations. It is mapped to a subset of CMS HCCs for beneficiaries 65 years of age or older. HCC models. 1. HCC, Medicare Advantage. A. Includes seniors and particular disabled populations. B. The prospective model uses data from a base year to predict enrollee healthcare costs for the following year. C. The diagnosis codes map to HCC conditions categories. D. The hierarchies assign numerical value, which translates to a risk adjustment factor. E. The risk determined each year. F. It is regulated by CMS. 2. HCC HHS. Affordable Care Act. A. Includes adults, children and infants in individual as well as small group plans. B. Concurrent model uses data from the current benefit year to calculate enrollee healthcare costs in the same year. C. Total of 15 models, 3 age groups, adult, child, infant, within 5 metal levels, platinum, gold, silver, bronze, catastrophic. D. Diagnosis codes map to HCC-HHS condition categories. E. Regulated by HHS and state. 3. Chronic illnesses and disability payment system. A. Includes Medicaid chronic illness and disability payment system. B. The diagnosis carry a value for risk, high, medium or low. C. CDPS and Medicaid prescription work by mapping diagnosis to a group of diagnoses categories that map to 58 CDPS categories for diseases and 45 prescription categories. D. It is regulated by the state. HCC revisions. On HCC version 24, there are 86 HCC categories and 9,797 diagnosis codes mapped to an HCC, while on version 28, there are 115 HCC categories and 7,770 diagnosis codes mapped to an HCC. Why the changes? Per CMS, quote, finalizes an important transition to an updated risk adjustment model that implements a set of common-sense, clinically based technical updates needed to keep MA payments up to date and to improve payment accuracy to MA plans. Unquote. 2025 HCC updates. 1. Infectious disease grouping. V24 HCC1, HIV and/or AIDS, and V24 HCC6, opportunistic infections, are completely unchanged. V24 HCC2, sepsis, has had 2 codes removed. T81.12XA, post-procedural septic shock, initial. T81.44XA, sepsis following a procedure, initial encounter. 2. Neoplasm disease group. V24 HCC were separated into multiple groups. V24 HCC8, metastatic cancer and acute leukemia, was split into 3 different V28 HCCs as described below. HCC 17, cancer metastatic to lung, liver, brain, and other organs, acute myeloid leukemia except promyelocytic. Received an average RAF increase of 1.422. HCC 18, cancer metastatic to bone, other and unspecified metastatic cancer, acute leukemia except myeloid, received an average RAF decrease of 0.274. HCC 22, bladder, colorectal, and other cancers, received an average RAF decrease of 2.262. V24 HCC9 had its codes divided into V28. HCC 17, cancer metastatic to lung, liver, brain, and other organs, acute myeloid leukemia except promyelocytic, received an average RAF increase of 3.093. HCC 19, myelodysplastic syndromes, multiple myeloma, and other cancers, received an average RAF increase of 0.710. HCC 20, lung and other severe cancers, received an average RAF increase of 0.151. HCC 22, bladder, colorectal, and other cancers, received an average RAF decrease of 0.591. V24 HCC 10 had its codes divided between V28. HCC 17, cancer metastatic to lung, liver, brain, and other organs, acute myeloid leukemia except promyelocytic, received an average RAF increase of 3.376. HCC 18, cancer metastatic to bone, other and unspecified metastatic cancer, acute leukemia except myeloid, received an average RAF increase of 1.681. HCC 19, myelodysplastic syndromes, multiple myeloma, and other cancers. HCC 20, lung and other severe cancers, received an average RAF increase of 0.435. HCC 21, lymphoma and other cancers, received an average RAF decrease of 0.046. HCC 22, bladder, colorectal, and other cancers, received an average RAF decrease of 0.308. HCC 23, prostate, breast, and other cancers and tumors, received an average RAF decrease of 0.476. V24 HCC 11 had its codes divided between V28. HCC 20, lung and other severe cancers, received an average RAF increase of 0.788. HCC 21, lymphoma and other cancers, received an average RAF increase of 0.307. HCC 22, bladder, colorectal, and other cancers, received an average RAF increase of 0.046. V24 HCC 12 had its coded split between V28. HCC 21, lymphoma and other cancers, received an average RAF increase of 0.464. HCC 23, prostate, breast, and other cancers and tumors, received an average RAF decrease of 0.034. 3. Diabetes disease group. V28 HCC 35, pancreas transplant status, has been added to this grouping at the top of the hierarchy and will absorb any diabetic codes when present. All forms of drug or chemically induced diabetes, E09, have been removed from the risk adjustment model. Diabetes mellitus without complication has had its RAF increased by an average of 0.077 across all populations, but diabetes mellitus with acute or chronic complications has had a RAF decrease by an average of 0.16. Details of the changes are below. V24 HCC 17, diabetes with acute complications, had all of its codes moved to V28. HCC 36, diabetes with severe acute complications, with the exception of drug or chemical-induced diabetes which were removed from the model in every V24 HCC, these codes received a RAF decrease of 0.160. V24 HCC 18, diabetes with severe acute complications, had all of its codes moved to V28. HCC 37, diabetes with chronic complications. These codes received a RAF decrease of 0.160. HCC 38, diabetes with glycemic, unspecified, or no complications, the codes for hypo and hyperglycemia were moved to V28. These codes received a RAF decrease of 0.160. V24 HCC 19, diabetes without complication, had all of its codes moved to V28. HCC 38, diabetes with glycemic, unspecified, or no complications. These codes received a RAF increase of 0.077. 4. Metabolic disease group. This grouping has had a large change. V24 HCC 21, protein calorie malnutrition, and all codes in that HCC were removed from the model. V24 HCC 22 had all of its codes moved to V28 HCC 48, morbid obesity, with an RAF decrease of 0.077. V24 HCC 23, other endocrine disorders, has had the most alterations and had several commonly coded conditions removed from the model and the rest of the codes split between V28. HCC 21, C88.0, Waldenström macroglobulinemia. These codes received a RAF increased of 0.379. HCC 49, specified lysosomal storage disorders, Pompe disease, Gaucher disease, and mucopolysaccharidosis. These codes received a RAF increase of 6.955. HCC 50, amyloidosis, porphyria, and other specified metabolic disorders, Lesch-Nyhan syndrome and various forms of amyloidosis and porphyria. These codes received a RAF increase of 0.377. HCC 51, Addison's and Cushing's diseases, acromegaly, and other specified endocrine disorders, Men's syndrome, Cushing disease, and adrenocortical insufficiency. These codes received a RAF increase of 0.256. HCC 115, specified immunodeficiencies and white blood cell disorders, D84.1, defects in the complement system. These codes received a RAF increase of 0.256. HCC 202, coma, brain compression/anoxic damage. E03.5, myxedema coma. These codes received a RAF increase of 0.177. 5. Liver disease group. 2 new HCCs were added to this grouping. HCC 62, liver transplant status/complications. HCC 68, cholangitis and obstruction of bile duct without gallstones. V24 HCC 27, end-stage liver disease, had all of its codes moved to V28. HCC 63, chronic liver failure/end-stage liver disorders, with the exception of 2 codes being removed from the model, K71.11, toxic liver disease with hepatic necrosis, with coma, and K72.01, acute and subacute hepatic failure with coma. These codes received a RAF increase of 0.082. V24 HCC 28, cirrhosis of liver, had most of its codes moved to V28. HCC 64, cirrhosis of liver, resulting in a RAF increase of 0.027 with a few exceptions. HCC 63, K70.40, alcoholic hepatic failure without coma, with a RAF increase of 0.675. Continuation of liver disease group. V28. HCC 68, cholangitis and obstruction of bile duct without gallstones, K74.3 and K74.5 for primary and unspecified biliary cirrhosis. These codes received a RAF decrease of 0.05. V24HCC29, chronic hepatitis, had all of its codes moved to V28. HCC 65, chronic hepatitis, with a RAF decrease of 0.019. 6. Gastrointestinal disease group. The major changes in this grouping. New HCC was added to this group. V28 HCC 77, intestine transplant status/complications. V24 HCC 35, inflammatory bowel disease, has been split into separate HCCs for Crohn's disease and one for ulcerative colitis. V24 HCC 33, intestinal obstruction/perforation, had all of its codes moved to V28. HCC 78, intestinal obstruction/perforation, with a RAF increase of 0.109. V24 HCC 34, chronic pancreatitis, had all of its codes moved to V28. HCC 79, chronic pancreatitis, with a RAF increase of 0.077. V24 HCC 35 had its code split between V28. HCC 80, Crohn's disease, regional enteritis, with a RAF increase of 0.156. HCC 81, ulcerative colitis, with a RAF decrease of 0.169. 7. Musculoskeletal disease group. The most significant change in this grouping is the addition of V28 HCC 94, systemic lupus erythematosus and other specified systemic connective tissue disorders, at the bottom of the hierarchy. V24 HCC 39, bone, joint, muscle infections/necrosis, had most of its codes moved to V28. HCC 92, bone, joint, muscle, severe soft tissue infections/necrosis, with a RAF increase of 0.061. An important exception to this is that 44 codes used to document osteonecrosis due to drugs were removed from the model. V24 HCC 40, rheumatoid arthritis and inflammatory connective tissue disease, had most of its codes moved to V28. HCC 93, rheumatoid arthritis and other specified inflammatory rheumatic disorders, with a RAF increase of 0.084, with a few exceptions. HCC 94 codes related to Reiter's disease, post-rheumatic arthropathy, giant cell arteritis, and systemic lupus erythematosus with a RAF decrease of 0.114. These are removed from the list. All forms of hyperparathyroidism, all forms of hyperaldosteronism, and drug-induced adrenocortical insufficiency. V28 HCC 21, protein-calorie malnutrition. 2 codes, K70.9 alcoholic liver disease unspecified and K70.41 alcoholic hepatic failure with coma, were removed from the model. An important exception to this is that 44 codes used to document osteonecrosis due to drugs were removed from the model. Codes used Sjogren's disease, polymyalgia rheumatica, and various forms of spondylopathies were removed from the model. Changes to HCCs by disease group. Shown here is a summary of the quantity of HCCs, and the number of each HCC per disease group, for V28 versus V24. Infections, quantity of HCCs for V24 is 3 while V28 is also 3. HCC numbers for V24 is 1 to 2, 6, and V28 is the same. Neoplasm, quantity of HCCs for V24 is 5 while V28 is 7. HCC numbers for V24 is 8 to 12 and V28 is 17 to 23. Diabetes, quantity of HCCs for V24 is 3 while V28 is 4. HCC numbers for V24 is 17 to 19 and V28 is 37 to 38. Metabolic, quantity of HCCs for V24 is 3 while V28 is 4. HCC numbers for V24 is 21 to 23 and V28 is 48 to 51. Liver, quantity of HCCs for V24 is 3 while V28 is 5. HCC numbers for V24 is 27 to 29 and V28 is 62 to 65, 68. GI, quantity of HCCs for V24 is 3 while V28 is 5. HCC numbers for V24 is 33 to 35 and V28 is 77 to 81. Musculoskeletal, quantity of HCCs for V24 is 2 while V28 is 3. HCC numbers for V24 is 39 to 40 and V28 is 92 to 94. Blood, quantity of HCCs for V24 is 3 while V28 is 7. HCC numbers for V24 is 46 to 48 and V28 is 107 to 115. Cognitive, quantity of HCCs for V24 is 2 while V28 is 3. HCC numbers for V24 is 51 to 52 and V28 is 25 to 127. Substance use disorder, quantity of HCCs for V24 is 3 while V28 is 5. HCC numbers for V24 is 54 to 56 and V28 is 135 to 139. Psychiatric, quantity of HCCs for V24 is 4 while V28 is 5. HCC numbers for V24 is 57 to 60 and V28 is 151 to 155. Spinal, quantity of HCCs for V24 is 3 while V28 is 3. HCC numbers for V24 is 70 to 71 and V28 is 180 to 182. Neurological, quantity of HCCs for V24 is 8 while V28 is 12. HCC numbers for V24 is 72 to 80 and V28 is 191 to 193, 195 to 202. Arrest, quantity of HCCs for V24 is 3 while V28 is 3. HCC numbers for V24 is 82 to 84 and V28 is 211 to 213. Heart, quantity of HCCs for V24 is 3 while V28 is 10. HCC numbers for V24 is 86 to 88 and V28 is 221 to 229, 238. Cerebrovascular, quantity of HCCs for V24 is 4 while V28 is 4. HCC numbers for V24 is 99 to 100, 103 to 104 and V28 is 248 to 249, 253 to 254. Vascular, quantity of HCCs for V24 is 3 while V28 is 3. HCC numbers for V24 is 106 to 108 and V28 is 263 to 264, 267. Lung, quantity of HCCs for V24 is 5 while V28 is 7. HCC numbers for V24 is 110 to 112, 114 to 115, and V28 is 276 to 280, 282 to 283. Quantity of HCCs for V24 is 2 while V28 is 2. HCC numbers for V24 is 122, 124, and V28 is 298, 300. Kidney quantity of HCCs for V24 is 5 while V28 is 4. HCC numbers for V24 is 135 to 138 and V28 is 326 to 329. Skin quantity of HCCs for V24 is 5 while V28 is 7. HCC numbers for V24 is 157 to 159, 161 to 162, and V28 is 379 to 383, 385, 387. Injury quantity of HCCs for V24 is 5 while V28 is 6. HCC numbers for V24 is 166 to 167, 169 to 170, 173, and V28 is 397 to 399, 401 to 402, 405. Complications quantity of HCCs for V24 is 1 while V28 is 0. HCC numbers for V24 is 176 and V28 is non-applicable. Transplant quantity of HCCs for V24 is 1 while V28 is 1. HCC numbers for V24 is 186 and V28 is 454. Openings quantity of HCCs for V24 is 1 while V28 is 1. HCC numbers for V24 is 188 and V28 is 463. Amputation quantity of HCCs for V24 is 1 while V28 is 1. HCC numbers for V24 is 189 and V28 is 409. Commonly missed HCC diagnoses. HCC 18. Diagnosis is diabetes with chronic complications. ICD-10 and code description are E11.21, type 2 diabetes mellitus with diabetic nephropathy. E11.22, type 2 diabetes mellitus with diabetic chronic kidney disease. E11.40, type 2 diabetes mellitus with diabetic neuropathy. E11.51, type 2 diabetes mellitus with diabetic peripheral vascular disease. HCC 19. Diagnosis is diabetes without complications. ICD-10 and code description is Z79.4, long-term, current, use of insulin. HCC 22. Diagnosis is morbid obesity. ICD-10 and code descriptions are E66.01, DM with diabetic chronic kidney disease. Z68.41-45, DMI 40 to 44.9, 45 to 49.9, 50 to 59.9, 60 to 69.9, 70, or greater. HCC 23. Diagnosis is other endocrine and metabolic disorders. ICD-10 and code description is E21.0 hyperparathyroidism. HCC 40. Diagnosis is rheumatoid arthritis and inflammatory connective tissue disease. ICD-10 and code description is M06.9, rheumatoid arthritis. HCC 48. Diagnosis is coagulation defects and other specified hematological disorders. ICD-10 and code descriptions are D68.51, factor V Leiden mutation. D69.6, thrombocytopenia. HCC 59. Diagnosis is major depressive, bipolar, and paranoid disorders. ICD-10 and code descriptions are F32.0, major depressive disorder, mild. F32.1, major depressive disorder, moderate. HCC 79. Diagnosis is seizure disorders and convulsions. ICD-10 and code description is G40.909, seizure disorder. HCC 85. Diagnosis is congestive heart failure. ICD-10 and code descriptions are I11.0, hypertensive heart disease with heart failure. I27.20, pulmonary hypertension. I50.22, chronic systolic congestive heart failure. I150.9, heart failure, unspecified. HCC 96. Diagnosis is specified heart arrhythmias. ICD-10 and code descriptions are I47.1, supraventricular tachycardia. I48.2, chronic atrial fibrillation. HCC 103. Diagnosis is hemiplegia, hemiparesis. ICD-10 and code description is I69.351, hemiplegia, hemiparesis following cerebral infarction affecting right dominant side. HCC 108. Diagnosis is vascular disease. ICD-10 and code descriptions are I71.4, abdominal aortic aneurysm, without rupture. I73.9, peripheral vascular disease. HCC 111. Diagnosis is chronic obstructive pulmonary disease. ICD-10 and code description is J44.9, chronic obstructive pulmonary disease. HCC 134. Diagnosis is dialysis status. ICD-10 and code description is Z99.2, dependence on renal dialysis. HCC 136. Diagnosis is chronic kidney disease, stage 5. ICD-10 and code descriptions are N18.6, end-stage renal disease. N18.5, chronic kidney disease, stage 5. HCC 137. Diagnosis is chronic kidney disease, stage 4. ICD-10 and code description is N18.4, chronic kidney disease, stage 4, severe. HCC 138. Diagnosis is chronic kidney disease, stage 3. ICD-10 and code descriptions are N18.31, chronic kidney disease, stage 3A, moderate. N18.32, chronic kidney disease, stage 3B, moderate. Sorry for the typo for HCC 137 and 138. ICD-10 code for HCC 137 is N18.4. The following are Z codes that carry HCC risk score weight that should be captured annually when applicable. For amputees, Z code status is Z89.41. Amputee description is great toe. Z code status is Z89.42. Amputee description is other toe. Z code status is Z89.43. Amputee description is foot. Z code status is Z89.44. Amputee description is ankle. Z code status is Z89.51. Amputee description is leg below knee. Z code status is Z89.61. Amputee description is leg above knee. Note, add sixth character for laterality. 1 is right, 2 is left. Example, right foot is Z89.431. Unspecified is Z89.9, which carries no HCC weight. For status, ostomy. Z code status is Z93.0. Description is tracheostomy status. Z code status is Z93.1. Description is gastrostomy status. Z code status is Z93.2. Description is ileostomy status. Z code status is Z93.4. Description is other artificial openings of the GI tract status. Z code status is Z93.50. Description is unspecified cystostomy status. Z code status is Z93.51. Description is cutaneous vesicostomy status. Z code status is Z93.52. Description is appendicovesicostomy status. Z code status is Z93.59. Description is other cystostomy status. Z code status is Z93.6. Description is other artificial opening of urinary tract status. Z code status is Z93.8. Description is other artificial opening status. For status, transplant. Z code status is Z94.1. Description is heart transplant status. Z code status is Z94.2. Description is lung transplant status. Z code status is Z94.3. Description is heart and lungs transplant status. Z code status is Z93.4. Description is liver transplant status. Z code status is Z94.81. Description is bone marrow transplant status. Z code status is Z94.82. Description is intestine transplant status. Z code status is Z94.83. Description is pancreas transplant status. Z code status is Z94.84. Description is stem cells transplant status. For renal dialysis, Z code status is Z99.2. Description is dependence on renal dialysis. Z code status is Z91.15. Description is noncompliance with renal dialysis. Implications for social determinants of health. Also new for 2025 are several HCCs related to social determinants of health, SDOH. These new HCCs include Z59.10, inadequate housing, unspecified. Z59.11, inadequate housing environmental temperature. Z59.12, Inadequate housing utilities. Z59.19, Other inadequate housing. Z59.811, Housing instability, housed, with risk of homelessness. Z59.812, Housing instability, housed, homelessness in past 12 months. Z59.819, Housing instability, housed unspecified. Using data analytics with HCCs. Exam healthcare patterns. 1. To improve clinical care. 2. Limit excessive spending. Goals. 1. Optimize reimbursement. 2. Decrease financial risk. 3. Improve care planning to reduce follow-up visits. Components. 1. Health plan data, membership, claims, prescription drugs, health plan data systems, diagnoses, pharmacy, lab, DME, patient surveys, care management. 2. Clinical algorithms, reported comorbidities past/present, pharmacy data, lab results, prior authorizations, DME. 3. Computer models, systems that identify specific conditions and group them into buckets. 4. Once comorbidities/chronic illnesses are placed into buckets, mathematical processes rank each comorbidity/illness actuary role. 5. Then, the comorbidities are mapped to providers/physicians based on specialty that will produce the most documentation to support coding of each comorbidity/illness. Building data analytics into risk adjustment program, CDI role. 1. Appropriate reimbursement to compensate for financial risk associated with sicker patients. 2. Identify health initiative patients, PSI, core measures. 3. Better risk identification and closure of HCC gap. 4. Strategies to close HCC gap. A. Optimize MSDRG assignment. B. Optimize APRDRG, SOI-ROM. C. Ensure to clarify all SOI-ROM data points. 42% of CMS HCCs are not CCs or MCCs. How to incorporate risk adjustment in PSI 90. Measures the hospital's quality of care for adult patients. The components of PSI 90 are: PS03, pressure ulcer. PS06, iatrogenic pneumothorax. PS08, in-hospital fall with fracture. PS09, perioperative hemorrhage and hematoma. PS10, physiologic, metabolic derangement. PS11, postoperative respiratory failure. PS12, perioperative PE and/or DVT. PS13, postoperative sepsis. PS14, wound dehiscence. PS15, accidental puncture and laceration. For each PSI listed in prior slide, there are two mechanisms used to complete the risk adjustment rate. Exclusions, absolute risk adjustment. Risk factors defined by Agency for Healthcare Research and Quality. Example, PS03, pressure ulcer. Exclusions, length of stay less than 3 days, transfer from hospital, SNF, or ICF, MDC-14, pregnancy, childbirth, puerperium, any listed diagnosis of hemiplegia and/or paraplegia, quadriplegia, spina bifida, anoxic brain damage, POA major skin conditions. Risk factors, hypertension with complications, COPD and/or pulmonary fibrosis, diabetes mellitus with or without complications, neurological conditions, renal failure, AIDS, HIV, hypothyroidism, anemia deficiencies, weight loss, drug abuse, psychiatry disorders, presence of solid tumors without metastasis. How to reduce risk exposure. 1. Documentation of chronic or acute on chronic is critical to reduce risk. 2. Chronicity of any condition impacts the patient's health over longer period of time. 3. Avoid the use of abbreviations. 4. Include all diagnoses from admission to discharge, condition ruled out, resolved, ruled in. 5. Documentation of history of undergoing current treatment would be considered a chronic condition. 6. Documentation of status for amputee, CABG, stents, organ transplants. Examples: systolic, diastolic, combined heart failure, acute, chronic, acute on chronic. Renal insufficiency, underlying CKD with specific stage. Cor pulmonale, acute, chronic. Bronchitis and/or COPD, acute, chronic, acute on chronic. Respiratory failure, acute, chronic, acute on chronic with underlying cause. Hypertension, always document cause and effect or underlying cause. Malignant neoplasms, list manifestation associated with neoplasm, document primary site, metastasis sites, recurrence, ongoing treatment. How to improve HCC accuracy. 1. Having an accurate problem list. Many healthcare organizations have been inputting data in an EMR for years now, resulting in lots of data, and most likely an inaccurate problem list. Ensuring an accurate problem list involves removing duplicative and inactive diagnoses, identifying key areas with discrete data in the EMR, and using a diagnosis preference list to include HCC suffix codes and RAF values as well as prioritize results. 2. Ensuring patients are seen in each calendar year. The first question to ask is, can you identify patients with chronic illnesses who have not been seen during the calendar year? If so, the next step is then do so, which may be easier said than done. One way to do this at a glance is to build a clinical dashboard that provides a snapshot of both EMR and claims data that provides a complete picture of patients not yet seen in a calendar year. Once the workgroup can identify these patients, they can match them with both visit and HCC coding gaps. The workgroup should acquire information at the system, region, clinic, or provider level and review with clinic staff regularly, such as on a quarterly basis. One best practice is to front-load visits for these patients early in the year when clinics have capacity. 3. Improving decision support and EMR optimization. Although educating providers is necessary to improve HCC coding accuracy, it's also important to build appropriate coding into the daily encounter workflow. Some potential strategies include having an ACO identifier flagged in the EMR, decision support tools that can be activated for select populations, and HCC diagnosis alerts for past codes. 4. Widespread education and communication. Because this is new work and certainly not intuitive, it's important to educate clinicians along the way. The biggest educational point to drive home to clinicians is not what score they should look for, but the importance of accuracy. Workgroups can educate clinicians on the clinical and financial value of specificity. They can also educate clinic staff about the specifics of the tools and workflows for patient management and reporting, and at a system level, education should center around the importance of appropriate risk adjustment and the impact quantification to justify resource allocation, as well as compliance. 5. Tracking performance and identifying opportunities. The last, and perhaps most important key initiative of the workgroup is to track performance and identify future opportunities for improvement. Measuring results provides the workgroup with compelling data to bring to stakeholders that shows what improvements were made, such as an increase in average RAF score, improvement in key problem list diagnoses, decrease in the number of members without an annual visit, an increase in the percentage of persistent condition diagnoses resolved. Once the workgroup has data to bring to stakeholders, the next step is to identify future opportunities for further improvements. One place to look for these is by reviewing unresolved persistent conditions for specific populations. The next 3 slides are appendices for CMS HCC listing V28. This slide shows the references used. Some slides contains the website for more information. Thank you for watching. Don't forget to click subscribe, follow and like buttons to get the latest updates. For $20, click or copy the link below for 1 hour continuing education. To obtain the certificate, you need to pass the test and fill out the evaluation.